This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we get started and introduce our speaker, we'd like to go over our program for those that are attending for the first time. We'll go over who we are, what is our program, upcoming events. We'll then introduce our speaker for this evening, and we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife, who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 70 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring speakers to you through the free EDS Awareness Educational Program. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website, edsawareness.com, for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for this program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. So just a general disclaimer, this presentation contains general information about EDS and related conditions. Members of the EDS community voluntarily participate in this program. The information is not advice, and if you're having medical problems, please call 911 and give the services that you need. Always consult your doctor before making any changes to your treatment.
Wanted to talk about some upcoming events. As you know, our webinars are held the first and third Tuesdays of each month at 7:30 p.m. Eastern Time. Our next speaker is on May 5th, and that will be Dr. Jekyll, and he'll be talking about Ehlers-Danlos and pregnancy and GYN issues. He's a professor of obstetrics and gynecology at UC Medical Health in Cincinnati. And on May 19th, I'm pleased to announce that Dr. Brad Tinkle will be giving a presentation. You can see more details on our website by going to edsawareness.com and clicking on the Webinars tab. Just a reminder that May is EDS Awareness Month. Hope you consider planning an awareness activity in your local community. And EDS Awareness shirts are available for only $10 each at bodysupportstore.com if you wish to purchase those as a group or individual. You can go there and find the details. For those attending live tonight, there will be an opportunity for Q&A after this presentation. Add your question at any time during the presentation by clicking on the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. And our long-awaited speaker tonight is Dr. Sood. He'll talk about GI issues with Ehlers-Danlos. He's a professor and chief of Pediatric Gastroenterology at Medical College of Wisconsin. He's also the medical director of Gastroenterology and the program director of Motility at Children's Hospital of Wisconsin. Dr. Sood was awarded Castle Connolly's Top Doctors in 2013. He has also spoken at the EDNF conference. He's been published in over 10 journals, including topics such as GI motility disorders, IBS, and GERD. So with that, I'd like to extend a very warm welcome to Dr. Sood. We've been looking forward to hearing your presentation, and we're going to go ahead and load your slides on the screen, and I'm going to turn over the microphone to you now, Dr. Sood. And it'll be just a moment till the slides will be coming up here in just a second.
Great. So welcome everybody, and thank you very much for joining us. I know we are having some technical issues, but I just want to take this opportunity to also thank John and Deanna for inviting me and for the incredible work they have been doing helping educate our community and some of the patients regarding healthcare concerns which some of the patients with EDS have. As Deanna mentioned, I was invited to the EDNF conference in Houston. I think that was a couple of years ago, and I have to say that I actually learned a lot myself attending that conference, and I didn't realize till that point that how many GI-related problems can go unnoticed and undiagnosed in some of the patients. So what I thought I'll do is I'm going to give you just a brief overview of what we know about and what's happened in the last maybe 5 to 6 years regarding understanding of gastrointestinal problems in Ehlers-Danlos, but also in hypermobility syndromes in general. I will then briefly take you through different parts of the gastrointestinal tract and focus on what kind of problems patients with hypermobility or EDS can have. And then I'll talk about some of the management options and what is new and emerging in functional and motility disorders, which happens to be the area I'm mainly interested in. So, John, if we can go to the next slide, please. So this was actually a slide I shared at the last EDNF conference, and this poster used to hang in my older daughter's bedroom, and Elastigirl was one of the favorite characters, and she could do incredible things, was very, very mobile and elastic, but I guess there were some downsides to that. And as we go through the understanding about hypermobility syndrome and Ehlers-Danlos, we realized that not much was known until about 70 years ago. The first phenotypic overlap of connective tissue disorders with Ehlers-Danlos type 3 was reported in 1980s. Subsequently, in the next 5 to 10 years, we started to understand some of the gynecological problems which adults with this condition can have. And understanding about chronic pain, dysautonomia, and functional motility disorders, which I'll be covering during my talk, was actually pretty much unknown till about 15 years ago. So if we go to the next slide, please. So we can go to the next one. I've already talked about this. So what I want to focus on today is mainly like hypermobility syndromes and EDS type 3. There are other disorders like Marfan's and osteogenesis imperfecta, which can also have GI problems, but I'm not going to cover those. I'm just going to mainly talk about hypermobility syndrome and EDS. Next. Next. And I apologize for the slow transition of the slides, but I guess this is the best we can do. So the first description of GI problems in patients with EDS was reported almost 55 years ago. And there were some patients who had spontaneous bowel perforation. Patients had GI hemorrhages, usually after endoscopy. Hiatal hernia with part of the stomach herniates into the chest was also reported. And adults, mainly in later 50s and 60s, had increased prevalence of diverticulums. But most of these disorders and reports were restricted to the adult age group. Next. So this is a study which was published about 5 years ago from France. They looked at 134 patients with EDS and reported some of the GI problems they have. And as you can see, about 50% of patients in this cohort had irritable bowel syndrome or IBS. So the main presentations for this condition are bloating. Some patients will have diarrhea. They can have urgency. Almost 40% patients had functional constipation, where they had infrequent or difficulty having bowel movements. Up to 70% of patients actually reported heartburn or gastroesophageal reflux disease. Next. This was followed by a study from our colleagues in London who have actually been very, very active in this field over the last 7-8 years. And one of the senior author, Dr. Aziz, is a good friend of mine, and he actually encouraged me to start looking at GI presentations in some of the kids with EDS and hypermobility. And their study, which was about 250 patients with hypermobility, some had EDS, reported that about a third of the patients actually had GI symptoms. Most common symptom was heartburn and postprandial fullness. So most of these patients would complain of feeling full after a small meal, or they had discomfort in the upper part of the abdomen. And I'll talk about another study which they are published looking at constipation and expulsion disorders in adults with hypermobility later on. Next. So we did a study about 4 years ago, which was published last year. We looked at 75 children who were referred to a tertiary gastroenterology clinic, which mainly focuses on functional and motility disorders. And we used a Beighton score to screen these patients for hypermobility, and some of them would then refer to genetics for testing for EDS. In our cohort, we found that 55% of our patients actually with hypermobility had functional gastrointestinal disorder, and the prevalence of hypermobility in general population is about 10%. So this was really significant. Next. And when we looked at the kind of disorders these patients have, our results were similar to what has been reported in adults. Almost 55% of our cohort had irritable bowel syndrome. About 45% had mainly upper abdominal pain and fulfilled the Rome criteria for dyspepsia. A small subset of patients had abdominal migraine and abdominal pain, which we couldn't categorize into one of the other groups. Next, please. When we looked at the symptoms, as you can see, almost 85 to 90% of our patients complained of dizziness. They also complained of feeling tired. A large proportion had nausea. They had problems falling asleep. And almost 50% of them actually had reported that they had passed out, like fainted once or more in their life. Next. So we were concerned that some of these patients may have what we call postural orthostatic tachycardia syndrome, where you have difficulty regulating the blood supply to your brain when you stand up from sitting position and you feel faint, or sometimes you can pass out. A few months after our study came out, the London group reported that they have looked at their hypermobile patients, and almost 78% of their patients actually had POTS-related symptoms, suggesting that there may be some difficulty in regulating the blood pressure, and there may be some problems with the vascular system. A lot of patients who have POTS also come to us with nausea and abdominal pain symptoms. So we see them interrelated. Next. So why would children with EDS or hypermobility have GI symptoms? Next. As you can see in this cartoon, if you look at the center, that's the lining of the bowel where all the enzymes and the secretions which help us digest food are produced. The outer lining is the blue lining called the submucosa, which is mainly connective tissue, and this is abnormal in EDS and patients who have hypermobility. The next layer, circular layer, go back. The next circular layer is the muscle and the nerve layer in the bowel. So the connective tissue layer is defective in patients we think who have hypermobility or EDS. And this is the main framework of the GI tract. So if you have a very elastic lining of the bowel, it will have a tendency to dilate, and that could be part of the problem. But there is communication between the connective tissue layer and the nerve lining and the muscle lining of the bowel. So there may be some problems there as well. Next, please. So when you go to a physician or a gastroenterologist and you have abdominal pain, most of the times they may give you a medication, and if you don't get better, they may offer you an endoscopy. Endoscopy is very good if you have a problem with the mucosal lining or the inner lining of the bowel. But endoscopy does not tell you what's happening underneath in the muscle or the nerve layer of the bowel, where most of the problems in patients who have hypermobility or EDS may be. And you may come back and the gastroenterologist may say, okay, you have abdominal pain, but your endoscopy is normal. Maybe I'll try you on some medication to suppress acid or acid blocking medication. But they can't really offer you more explanation than that. Next, please. You can double click, John, here. So patients who have normal looking mucosal lining of the bowel and their lab workup is negative, which will be the case if you have a functional or motility disorders, which most patients which I see with hypermobility or EDS will have. We don't really understand what the underlying mechanism or the cause of the symptoms is. And we will categorize these into what we call functional GI disorders. Now, as we look at the history of medical people, how we understand functional GI disorders, if you go back into the literature in 1950s and 60s, most of the gastroenterologists would think that if you have functional pain, you probably have a psychosocial disorder. So they may ask you questions like, do you have any family problems? Do you get on with your wife or your husband? Do you have teenage children, or do you have problems with your kids? So trying to figure out if there are any stressors in your life. However, in 1970s and 80s, people begin to look at the bowel motility, and I'll talk a little bit more in detail about this, and started realizing that there were abnormalities in the bowel motility. About 15 years later, we had specialized scanners where we could actually look at the sensory function of the bowel, how the bowel communicates with the brain, and are there problems with the perception of sensations from the bowel, and that's called visceral hyperalgesia. And more recently, in the last 10 years, we have started to understand what are the genetic causes which may be causing some of these functional GI disorders. Are there problems in the immune system in the bowel and the nerve lining of the bowel which may be defective, which I was alluding to earlier? And I think some of the patients who have EDS or hypermobility may have some neuroimmune dysfunction. We know there is a study from Europe which is suggesting, it's not been published but been presented at meetings, that patients who have hypermobility may actually be more prone to having what we call inflammatory bowel disease, where the immune system of the bowel does not work very well. Next. So John, if you can click 3 times here, please, slowly. So what I'm going to do is to take you through the gastrointestinal tract. We will first look at what problems patients with EDS can have in the esophagus. We'll then move on to the stomach, and then in the last part of my presentation, I'll talk about the small and the large bowel. Next, please. So gastroesophageal reflux disease or heartburn is very common, and as I mentioned, in adults, about 70% of patients with hypermobility will have reflux symptoms. The common presenting symptoms to a physician or for a patient are chest pain. There may be problem or pain in the upper abdomen in children, especially young children. They can't really describe their symptoms very well. They may complain of regurgitation of the stomach contents and sometimes acid into their throat. They may have difficulty swallowing. Next, please. And as we look at the top of the stomach as shown in this cartoon, there is a very complex mechanism which helps to keep the stomach acid from getting back into the esophagus, and part of this defense mechanism is a specialized ring of muscle called the lower esophageal sphincter. And I don't have a cursor here, so I can't show you, but if you can look at this, the flat lines on either side of the tube or the esophagus is the diaphragm, which also pinches the top of the stomach or the lower end of the esophagus and prevents any acid from leaking back into the stomach. Some patients who have a hypermobility and have weak diaphragm, the part of the stomach may herniate into the chest, or the circular muscle ring or the lower esophageal sphincter is not working very well. So they will have slow leakage of acid into the esophagus. Next, please. And what this can do is to irritate the lining of the esophagus, and sometimes you can get ulcers or erosion in the lining of the esophagus as shown in this endoscopy picture. This should be normally like the inside of your mouth, nice, smooth, and pink. So all these streaks or yellow streaks you're seeing is pus, and then there are ulcers at the bottom where the acid has burned the lining of the esophagus. Now, next, please. So a lot of times when you go to a gastroenterologist and they do an endoscopy, if you have a acid-induced damage to the lining of the esophagus, then you get a diagnosis. However, if the lining of the esophagus looks okay, then you really don't know if you have some leakage of acid, but it's not bad enough to cause any damage there. Then we will use what we call a pH impedance study. This is a small little tube which goes through the nose and sits at the top of the stomach, and as you can see at the bottom end of the slide, there is a small box called a digitrapper which is connected to this tube, and it records what the pH of the the lower part of the esophagus is for 24 hours. So when you come back, we can download the data and can get a 24-hour profile of the pH of the lower esophagus. So each time you get a leak of acid into the esophagus, we can tell how long it stays there, how bad it is, and does it correlate to the symptoms. And some people will regard pH impedance as one of the gold standard tests for diagnosing reflux. And we use it in selective children who have symptoms which do not respond to conventional therapy or the endoscopies are not diagnostic. Next. And as I mentioned, maybe doing a imaging study where you drink a white paste or a barium paste, and this is mainly done if we are suspecting that there may be some narrowing, or sometimes you can get a stricture from the heartburn-induced damage to the lining of the esophagus, or if you're suspecting that there may be part of the stomach which has herniated into the esophagus. This test is not a good way of diagnosing reflux. It's only used for diagnosing any anatomical problems which may be there. So if you go to a radiologist and you have an upper GI and they tell you that you have reflux, then don't believe them. Go and talk to your gastroenterologist instead. Next, please. So how do we treat reflux? You can get over-the-counter drugs like Tums. You can get H2 blockers. The common ones are cimetidine and ranitidine. A little bit more potent suppressants of acid production in the stomach are PPIs, which are now available over the counter. There are a couple of prokinetics which help to empty the stomach a little bit faster and clear the acid from the stomach. The common one which we use in children is erythromycin, but doesn't work in the long run, and there aren't any good prokinetic agents or agents which help to empty the stomach faster in children. Next, please. If this therapy does not work, then if the PPIs do not work, then some patients may need what we call a fundoplication. However, with PPI therapy now, fundoplication is really needed in children, and if you are considering fundoplication, it's extremely important that you have more evaluation to make sure you do not have abnormalities of the motility of the stomach or the small bowel before you consider a fundoplication. So it might be a good idea to speak to a motility specialist. Next, please. We have looked at our patients who have a normal esophageal lining, and this is a study we published last year. Some patients may have normal pH impedance study and they may have normal endoscopy, but when we look at the lining of the esophagus as shown in the gray picture, it's an electron microscopy image of the cells of the esophagus, and the light gray little parts which you see are the spaces between the cells. And what we found is that patients who have heartburn type symptoms, these spaces are opened up and the lining of the esophagus becomes really leaky. So the acid can leak and irritate the nerve lining in the bowel. So we have now proposed that this may be a test which can be helpful in patients who otherwise have normal workup for reflux-related symptoms. Next, please. So I'm going to move on to the stomach and what problems we can face in the stomach. Now, stomach is not just a bag to store the food, but it actually helps to break down and churn the food into a thin paste. So the food which leaves the stomach is completely churned into like a paste, and the stomach knows that the size of the particles leaving the stomach is more than a couple of millimeters. It does not allow them to enter into the small bowel where the food is going to be digested. So the stomach is also connected to the bowel, and if the food enters too fast into the small bowel, there can be a message going back to the stomach to slow down the emptying. The stomach is very well regulated, the organ in our body, similar to the heart. Next, please. So the problems with children with functional pain, next, please, can have a threefold. One is that the stomach in some of the patients can become a little bit stiff. Next, please. So usually when you start eating a meal, the stomach relaxes, and what we call adaptive relaxation in anticipation of food coming to the stomach, it will gradually dilate. But if the stomach is like a tennis ball and it can't descend, then the person will feel full after eating a small meal. And if you keep eating, then it will cause discomfort. Sometimes it can trigger nausea and vomiting. Next, please. And this has been very well studied and reported in multiple publications in children who have upper abdominal pain, especially after eating a meal. We looked at a fairly simple test which we could use in the office, where we ask children who come empty stomach in the morning, and we give them a big bottle of water and we ask them to drink, and keep drinking till they feel full. So this is a bedside or an office-based test which can actually tell you how flexible or how pliant the stomach is. And if the stomach is really stiff, the kids will drink much less water than a normal child will, and we have used this in some of our patients. Next, please. And next, please. And as I mentioned, that the other function of the stomach is to churn the food up and make sure it's a thin paste. How do we measure if the stomach emptying is happening at the right rate, or is the stomach too slow or too fast? We use what we call a gastric emptying scan for this, and what we use is a radioisotope labeled meal. Most hospitals will use scrambled egg, which has this isotope added to the scrambled egg before you cook it. And you take this meal, and then you have images taken with a gamma camera for about 4 hours. And we can tell from these images what percentage of the food is still in the stomach at first, second, third, and fourth hour. So if you have slow emptying, then we can pick that up with gastric emptying scans. Next, please. So patients who have mainly epigastric or upper abdominal pain, we use some of these tests to figure out whether they have a peptic ulcer, whether they have a problem with the stomach compliance, do they have a problem with too slow stomach emptying, or the stomach is not able to churn the food up, and that's called gastroparesis. And depending on the diagnostic workup, we usually target the most bothersome symptoms. So if you are feeling full and the stomach is slow in emptying, then we will recommend small frequent meals. Cutting out fiber and fat, which slows down the stomach emptying, can be helpful. And as I mentioned, we can use prokinetics, which are medicines which will help emptying the stomach a little bit faster, but unfortunately we don't have good prokinetics which are approved for use in children. Most commonly we will use erythromycin. Cyproheptadine is an antihistamine, and it also helps to stimulate appetite, but it relaxes the stomach as well. So we use this drug in patients who have volume intolerance, or what we call poor stomach compliance. If you're having a lot of pain, maybe tricyclic antidepressants, which work on the nerve lining of the bowel, can be helpful. And commonly used tricyclic antidepressant in GI practice is amitriptyline. Neurontin again works on the nerve endings of the bowel and can be helpful to alleviate abdominal pain. If you have dizziness and POTS type of symptoms, optimizing fluid intake, making sure you're taking enough salt in your diet. And if fluid and salt are not enough, then we use a hormone called fludrocortisone, which helps the kidneys to retain salt, and that can be helpful to, number one, control nausea and POTS type of symptoms or dizziness. Next, please. Next, please. More recently, there are gastric pacers, and as you can see in the top right-hand corner, it's a little disc which is embedded under the skin in the upper part of the belly, and through two wires we connect it to the wall of the stomach. This has been used in adults who have slow gastric emptying, or what we call gastroparesis. There is one study from Columbus which has shown that it's very effective in controlling symptoms, mainly nausea and vomiting. Doesn't work very well if the predominant symptom is abdominal pain. And it doesn't actually help with improving the emptying of the stomach, but somehow cuts the messages which are going to the brain from the stomach and helps with controlling nausea and vomiting. So a lot of adults and children who get this procedure will be able to eat normally and are not bothered by nausea or vomiting, and then can start functioning normally. So it may be a useful treatment modality for patients who do not respond to conventional medical management. Next, please. So moving on to the small bowel, this is the part where the digestion and absorption of all the food happens. As you can see on the right-hand side, it's very richly supplied by nerve lining, and after the brain, the nerve lining of the bowel is the most important part, or what we call the gut brain. A lot of times patients who have small bowel motility or functional disorders may have problems with the nerve and the muscle lining of the bowel. This may not be very common in patients who have hypermobility, but there are a couple of reports which I will share with you, which are suggesting that some patients may have issues with the smooth muscle lining of the bowel. Next, please. So when we want to evaluate the small bowel, we usually use a technique called intraduodenal manometry. It's a small little tube which goes past the stomach into the small bowel, and it has pressure sensors. And this test can take up to 6 hours. Next, please. And we can use drugs which work on the nerve lining of the bowel, and looking at the pattern of the contractions, we can figure out if the stomach emptying and the small bowel motility are working in coordination and can influence each other, which should happen normally. And if there is a problem with the nerve or the muscle lining of the bowel, we do not see this normal motility pattern. And this can be a good screening test for patients who otherwise have a normal workup but continue to have abdominal distension, abdominal pain, nausea, or vomiting. Next, please. In the past, we were not able to look at, next please, look at the deeper lining of the bowel. And as I mentioned, endoscopy, next please, will only allow you to look at the mucosa or the innermost lining of the bowel. Now what we can do is that to look at the deeper lining of the bowel, we need to do what we call full thickness biopsies. And in the past, you would need a surgery and an operation to get full thickness biopsies. But now we can use laparoscopes, and in adults, you can actually have specialized endoscopes through which you can go into the deeper lining of the bowel and get quite a thick piece of the bowel to look under the microscope. Next, please. And this can be useful in patients who have chronic intractable symptoms, allows you to look at the muscle lining. And as you can see in this child, there was an abnormality in the smooth muscle lining of the bowel in Ehlers-Danlos syndrome. And this provided an answer to the problem this child was having, such as abdominal distension, pain, and vomiting, and difficulty digesting food and absorbing it. So some of these children may actually need stomach tubes, or what we call gastrostomy. Some kids are so badly affected that they may need parenteral nutrition support. Next, please. You can click twice, John. We can miss the next slide. So as I mentioned, this is adult study from the London group looking at large bowel problems in patients with hypermobility. And as you can see, almost a third of the patients had chronic intractable constipation. Most of them were needing laxatives, but some patients were actually needing manual evacuation, and adults would report that they had to insert a finger to fish out hard stool. And next, please. And part of this problem can be that some patients will develop chronic stool impaction. Next, please. And what we call megarectum. So the rectum can become really dilated. Next, please. And as the bowel becomes really dilated, the propulsive force or the ability to push the contents in the bowel diminishes. And this can lead to stasis of food and stool in the bowel and leads to backup, and the dilatation of the distension gets progressively worse with years. Next, please. And a subset of patients can actually then have problems expelling the stool. So you feel the urge, but when you sit on the toilet and you try and push the stool out, it doesn't come out. This can happen if the defecation process is uncoordinated, or what we call dyssynergic defecation. And there are different types of it, but majority of patients will then squeeze the anal opening or the pelvic floor tight, and they're pushing with their belly. And a lot of times when you push against a partially closed anal opening, no stool will come out, or some patients will say that they have really thin pencil-like stools, which is a common problem in uncoordinated or dyssynergic defecation. Next, please. We use what we call anorectal manometry, which you can see in this slide, and this helps us to look at, next, please, look at the distension of the rectum, the sensation of the rectum, and also help us to look at what we call the anal sphincter. Next, please. And we can look at the coordination of the defecation activity. Some patients with very dilated bowel will have what we call slow transits. We use these little rings, plastic rings coated with barium. You take them on 3 consecutive mornings. Go back, please. 3 consecutive mornings, and we do an X-ray on day 4. And depending on the distribution of the rings, we can then tell how long it takes for the contents which you've eaten to reach the lower end of the bowel. So if the bowel motility is compromised, then the food moves really slowly, or what we call slow transit constipation. Next, please. So if you want to look at the motility of the large bowel in a little bit more detail, we use what we call the colon manometry. And as you can see on the X-ray picture in the top half of the slide, there are little beads which are pressure sensors, and they're spanning the entire large bowel. And in a normal person, when you have a bowel movement, the streaks, red streaks, which you see are actually quite forceful contractions in the bowel, which start on the right-hand side and then push the stool into the rectum within about 2 minutes, which then ends up in a bowel movement. So if you have a motility problem, part of the large bowel may be too dilated and weak and doesn't work, then in that case you may do some bowel resection. Sometimes the entire bowel may not work. Next, please. So doing a functional and a motility workup in patients who have intractable constipation can be helpful to plan any surgical intervention. So the conventional treatment for chronic constipation is laxatives, and the common ones which we use are in pediatric patients are polyethylene glycol, mineral oil, milk of magnesia. Most of these are osmotic agents. They just retain moisture in the stool and will help to make the stool soft. Senna and bisacodyl are what we call stimulant laxatives. They actually make the bowel contract and push the stool out. There's a newer drug called lubiprostone, which has been used in adults with constipation. There is one safety study in children which did show that it's helpful in constipation, and the side effect profile was very similar to what was reported in adult studies. There is a multi-center study going on at the moment in pediatric population. Sometimes we will use this in patients who are not responding to some of the conventional laxatives. If laxatives don't work, then the options will be to do what we call a cecostomy, which you can see in the images. It's a small little button with a flap on top, and you can open the flap and give what we call an antigrade enema. So you can put about 500 ml to a liter of normal saline, which then helps to clean the entire large bowel, and most patients will have a bowel movement within about 15-20 minutes. So you don't have to take multiple laxatives with this. About 40% of patients after about a year or so will be able to wean themselves off the antigrade enemas, and some actually have long-term recovery. Next, please. One of the newer treatment modalities which has been used in patients who have chronic intractable constipation or responding to medication or have frequent accidents where stool leaks out is called sacral neuromodulation or InterStim. This is a small disc which is connected through a wire to the bottom of the spine, and then through the pacemaker or the sacral neuromodulator, very weak electrical impulses go to the bottom of the spine. And this has been used in adults who have chronic constipation and stool incontinence, and about 50% of patients actually report a complete resolution of symptoms. Pediatric data is a little bit sparse. There is one study from Europe which looked at 13 patients who had chronic intractable constipation, which did not improve with any medical management, and they had this device put in. The follow-up in this published study was up to a year. All patients showed improvement in the frequency of bowel movements, and most of them actually stopped having stool leakage as well. We have started doing this, and our experience is in about 6 patients. We started doing this last year. So the longest we've had this is about a year, and the last patient we did was about 3 months ago. And all our patients have actually reported significant improvement after this device. However, as I said, the follow-up is only 3 months to 12 months. So we would like to see in a little bit more longitudinal studies whether this is going to be a promising treatment modality, but our results so far are very optimistic. Next, please. You can click twice, John. We can go miss the next slide. I think we're running out of time. Keep going. Keep going. So I'll probably summarize what I've said so far. As I mentioned, the data so far shows that patients who have hypermobility or have EDS are prone to having functional and motility disorders of the bowel. A lot of times, maybe 5 years ago, patients coming to our center, we weren't aware of this overlap in hypermobility and GI symptoms, and we actually didn't screen our patients. But now we do this actively, and we are finding that a large majority of our patients who have motility and functional disorders also have hypermobility. We now routinely send our patients who have persistent or chronic symptoms to our genetic colleagues to screen for EDS. What I think and what the adult data would suggest is that the altered biomechanics of the bowel with the defective connective tissue lining, there may be some subtle abnormalities in the nerve and the muscle lining, may predispose to abnormal propulsion of bowel contents, and this may be the reason why we have the symptoms which I've mentioned earlier. So when you go to a gastroenterologist who only can offer you a diagnostic endoscopy but doesn't have the setup to look at the bowel sensory and motility assessment, then you may not be able to get to the bottom of things. So if you have symptoms which are persisting and the routine workup at your local gastroenterologist is normal, then it might be an idea to actually discuss this with your gastroenterologist or your pediatrician to see if it would be useful to go to a center which specializes in bowel motility disorders. There are about 7 or 8 pediatric centers, and one happens to be in Cincinnati, where Diana is. And having somebody evaluate your child at these centers may actually be very helpful. So, next slide, please. I'll just introduce my team at Milwaukee. We actually have one of the largest motility and functional GI disorders pediatric center in the country. And I have 5 other colleagues who specialize in this area. Gisela Chiliminski is the Autonomic specialist and was one of the senior authors on our study, which I shared with you. Her husband, Tom Chiliminski, is an adult neurologist but has an interest in pediatric autonomic and abdominal pain disorders. I specialize mainly in bowel motility disorders. Dr. Lee is a world authority in pediatric nausea and vomiting. Dr. Miranda is an expert in abdominal pain and is studying the connection between the bowel and the brain. Dr. Kovacic, who's the youngest member of our team, is focusing in nausea and was the first author on the publication which I shared in hypermobile children. Next slide, please. So if you need to contact our center or you want to speak to any of these specialists, we actually, for out-of-state patients, we have an access center, and I have included the direct line number to contact our access center, and they will help to coordinate the visit and have you see one of our team members. The patients who are calling within the state can directly see one of our specialists in the clinic, and this is the direct line number for this consultations. So I'll finish with that. Thank you very much for staying with us, and I apologize again for the transition of the slide was a little bit slow and took me longer than I had anticipated. So I'll be happy to answer any questions.
Thank you, Dr. Sood. That was very informative. We're going to go ahead to the Q&A if we can, and wanted to find out if John wanted me to read those, or what is the best way to provide the Q&A.
Can Dr. Sood get to the Q&A at the top?
Okay, I'll try.
There'll be a Q&A box at the top in the middle.
Yeah, I have the Q&A. So
okay,
I'm going to start. Yeah, I have the box up, and I can see the first question is, it says, hi, I am 37-year-old. I have EDS type 3 hypermobility with many types 4 symptoms but negative blood work. I have significantly prolonged small bowel transit of over 6 hours. I had the IBS and GERD since childhood. I'm always really constipated, bloated, gassy, pain, etc. I have tried probiotics, Colace, more with little or no relief. What can I do? This is so hard. So I think when I went to the EDNF conference, this was the usual story which I was hearing, and I think it's going to be very difficult to give personal advice to people about their symptoms. But in general, I would say that if you haven't seen an adult specialist who has an interest in bowel motility disorders, I would strongly recommend that you see that. I think just telling you that your bowel transit is slow doesn't help you that much. I think you may need more specialized tests. I would also recommend that you consider some of the treatment modalities, and I don't know what medicines you have tried so far, but if you have slow transits because of slow gastric emptying or the large bowel transit is slow, then maybe trying sacral neuromodulation or gastric pacing may be helpful for you. So the next question is, my daughter is now 25. Her emptying study showed accelerated motility. However, when she vomits, it's undigested food from 5 to 10 hours prior. Can someone have both accelerated and slow emptying? And the answer is yes, you can, because as I mentioned, the stomach is very well regulated. So if you have very rapid emptying to begin with, then your small bowel will send signals to the stomach and slow the stomach emptying down and may even stop it. So yes, it is possible. So can I recommend a doctor in New York City or New Jersey? So this, I assume, is a pediatric gastroenterologist in New York City. So two people, I think Dr. Nader Yusuf is a motility specialist and is based in New York, and the other person will be Dr. Tom Sisiraga. He's at Cornell, and he was one of my fellows, and he was visiting us a couple of weeks ago, so that might actually be a good contact for you. Is surgery for GERD fundoplication recommended for EDS patients with severe GERD? I think if your symptoms are not responding to, excuse me, to PPI therapy, then I think considering fundoplication will be a reasonable thing, but you need to be worked up properly. If you have a hiatal hernia that needs to be looked at, I will usually recommend to my patients that they should have gastric emptying studies prior to considering fundoplication, because if you have slow gastric emptying, then fundoplication may not be a good procedure. So speaking to a pediatric gastroenterologist and having appropriate workup before you do a fundoplication would be a sensible thing to do. Next question is, my daughter with EDS have a tendency to cough and have to clear her throat after eating. Acid reducing medicine seem to help this. Does this seem to be connected to EDS? Well, the answer is, I assume that your daughter may have reflux-related symptom, and as I mentioned in my presentation, reflux is a common problem in EDS, so the answer would be yes, but there can be other reasons why children will clear their throat, and that needs to be looked into, but yes, reflux could be one of the possibilities. So next question is it safe to use PPIs for an extended period of time? I have been taking Nexium for 15 years, and if I miss a dose, I have heartburn, abdominal pain, and nausea. So the answer to that question will be PPIs can be used long-term. However, there are some complications which have been reported. There is increased prevalence of community-acquired infection. Some patients who are on PPIs can develop what we call C. diff colitis or enterocolitis. And there is some suggestion that PPI long-term use may predispose to reduced bone density, so that needs to be looked into. So I would say that if you've been on a PPI for 15 years, you need to follow up with I assume you're adults, with an adult gastroenterologist. One piece of advice I will give you is that when you use PPIs for a very long time and you suddenly stop them, you may get what we call rebound acid production. So even normal people, after taking PPIs for a month, even if they have no underlying problem, will develop heartburn symptoms because of this rebound in acid production after stopping PPI suddenly. So what I recommend my patients is that you should wean yourself from a PPI. Don't suddenly stop them cold turkey. Gradually reduce the dose over 2, 3, 4 weeks. So that can be done after talking to your gastroenterologist or your family doctor. So then I think there are lots of these questions, John, so just help me out. Do you want me to go them? There are some questions which are really long, so I'm going to maybe skip those for the...
Yes, that's fine. If you need
because
to
of time, I think. So the next one I can find here is, my daughter and I have chronic gastritis, inflammation found with endoscopy, even on acid reducers. Are there other treatments? Now, I think I would not like to comment on this, because if you have chronic gastritis, then I would like to find out why you have chronic gastritis, and the treatment will have to depend on what kind of inflammation you have in there, which I think your gastroenterologist should be able to tell you after talking to the pathologist and reviewing those slides. So if someone experiences bloating, early satiety, constipation, GI pain, nausea, etc., is that generally diagnosed as IBS, given that all investigations come back as normal? So this is what I was trying to allude during my presentation, and I think when you have diagnostic workup, which includes upper endoscopy and colonoscopies, or maybe 2 or 3 colonoscopies, and you've had an upper GI, that's not a complete diagnostic workup to figure out what the underlying problem can be. So you may need some of the specialized diagnostic workup, which I mentioned during my slide. Now, not all patients who have early satiety and bloating have IBS, but there is, so bloating and early satiety is functional dyspepsia. Constipation can be related to IBS. Adults who have IBS will have other functional disorders like dyspepsia I'm mentioning. So to figure out what's the predominant cause of the symptoms may need you to go to a specialized adult gastroenterologist. I assume this is an adult question. Can the stomach pain after eating be mistaken for ulcer symptoms? The answer is yes. And if your symptoms are chronic, then you need to get an endoscopy. And if the endoscopy is normal, then you may need further workup, which I've already mentioned. So if I have non-diabetic gastroparesis, GERD, hiatal hernia, leaky gut, NASH, a fish mouth, are all these EDS related? They can be related to EDS, yes. My son and I both have EDS. We were diagnosed with gastroesophageal reflux disease and have had issues with getting food stuck. We were also diagnosed with EOE after endoscopy. I was led to believe that EOE was the cause of GI issues. It seems like EDS causes these issues without the EOE. I would like to know if EOE makes symptoms worse. Answer is yes. I think you probably then have 2 reasons to have some of the symptoms which you're describing. I would recommend that you have follow-up with your gastroenterologist regularly and make sure you take long-term treatment for EOE. There is some suggestion that if you undertreat EOE, then in long run, some patients may develop strictures. So adults who have EOE have what we call stricture or narrowing of the esophagus. And that if that develops, then it may need regular dilatation, which is not a very nice thing to have to undergo repeatedly. So the answer to your question is that yes, I think you need to have a gastroenterologist who can deal with EOE, but also with reflux and associated symptoms, which could be due to EDS. My daughter has difficulty swallowing. She has loss of muscle mass in the throat and thinning voice box. Can anything be done for that? I'm sorry, I can't answer that. You need to talk to an ENT specialist for that. It's not a GI related issue. The next question is really long, so I'm going to go to the next one. Can craniocervical instability cause swallowing problems? If so, what can be done? Yes, craniocervical instability can cause swallowing problems, and you need to speak to a neurosurgeon to address that. If the spine MRI and neurosurgery give you all clear, then you need to go to a swallowing specialist. Depending on the age, pediatric age group patients can come to our center, and there are adult centers which mainly deal with swallowing, so you need to see a specialist there. Okay. How would you recommend handling trying to prevent constipation after surgery from pain medication? So there are, I think you need to speak to a gastroenterologist and have laxatives. There are certain laxatives which are specific for what I assume is opioid-related constipation. So you may need one of those. So you need to speak to a specialist. I have been diagnosed with EDS, classical type, POTS, and gastroparesis. I usually alternate between constipation and diarrhea. Recently, I have been constipated all the time despite using laxatives. I've been having lower back pain and radiates to the pelvis. I'm wondering if this symptom is indicative of constipation, or should I be concerned that more is going on here? When should I be concerned that a back blockage is occurring or something serious? So I am a pediatric gastroenterologist, and I'm going to talk about pediatric-related constipation. I cannot give you advice about adult constipation because for adults, there are always concerns about, if you have blockage, could there be underlying mass or a tumor? That needs to be addressed. For pediatric patients, we usually don't have high risk of tumors and things, so we are not that worried. But in classical patients, if you have lower back pain and you have really bad constipation, that would be a sign that you may be developing a megarectum or a megacolon, and you need to see a motility specialist who has an interest in dealing with chronic intractable constipation. Okay, so this is an interesting one. So it's very long, but I'm going to read the first half of the question. Thank you, Dr. Sood, for the lecture tonight. Do you think that common toilet seat contributes to constipation? In other countries, there is a squatting position that is set to make evacuation easier. And the answer is yes. Thank you very much for bringing that up. So most of the children who are sitting on toilets with their legs hanging, we recommend that you put a stool under their feet so they can actually relax. And the ideal position for a child sitting on the toilet should be that their hips should be flexed. So you are partially squatting into the toilet. So squatting will have to relax the pelvic floor, and I mentioned dyssynergia where people will tend to squeeze the pelvic floor. So if you're squatting, you don't tend to do that, and that can help with the elimination process. So this is an important point. So thank you very much for bringing this up. Do we still have time, or?
Yes,
So
you can go
I
ahead.
think I'm going to probably end up with maybe last couple of questions. My daughter is 14, and we are not sure on the gastric issues. What we know is when she drinks water or liquid, it stays there for a few hours. Would you think that this is delayed gastric emptying? So usually patients who have delayed gastric emptying, as I mentioned, will have, they feel full after eating a small amount. They may have feeling of fullness of pain after a meal. You may have nausea. You may have vomiting. Now, if your daughter doesn't have any of these symptoms, but you probably notice that she may bring up water or liquid a few hours after a meal, then I wouldn't get too worried about it. But if she has some of the symptoms which I explained, then yes, maybe she may have delayed gastric emptying, which may need to be looked into. So, I think I'm just scrolling down, and there are some questions about adult patients, and I'm not going to comment on them, but there is one patient. I hiccup often, mostly just once, but sometimes have a bout of hiccups. They're always loud and strong. It happens daily. I've been told that this is due to my GERD. Have you found an occurrence similar to this in those with EDS? And the answer is no. Hiccups usually happen if you have irritation of the diaphragm, and if you're having chronic hiccups, you may need to go and see a neurologist rather than a gastroenterologist, because there are some medicines which can be used to alleviate chronic recurrent hiccups. Whether this is going to be related to GERD, I can't really comment on that, but usually GERD patients should not have intractable hiccups. So I think I'm going to finish off with this last question, and thank you very much for staying with us.
Okay.
Well, thank you very much, Doctor. We appreciate the very in-depth evaluation that you gave us of the gastrointestinal issues, and many of our EDS members have those. So this is one that we had really been looking forward to presenting. So we really appreciate your time and the program that you put together, very graphic, so that we got a tremendous amount of information. So we really appreciate that.
Thank you, Dr. Sood. Yeah, the visuals helped tremendously for us to really understand the process of what was going on in the GI tract.
I wish I had control on the slides, because I think it was a little bit slow at times, and I hope people...
Oh, that's okay. Give people time to digest what you were saying. No pun intended. So fabulous. All right. I wanted to remind everyone that Dr. Sood does have a very involved team in Wisconsin. If there's anything else you wanted to mention about how people can get in touch with you, or anything else about your clinic, feel free to do that before we wrap up tonight.
Great, thank you.
And we'll provide the
links on our site that will provide links to your clinic, and also to some of the content related to your clinic. So we want people to be able to look at that. Also, the slides and the recording will be on our site, hopefully tomorrow. That's generally what we try to do. And we want to make sure you're aware that in 2 weeks we have another presentation on May 5th, and those interested in issues related to pregnancy, which is a big issue with EDS women, you can look forward to attending that. We also encourage you to look at our bodysupportstore.com. That is sponsoring this program this evening. There's over 250 products related to EDS, pillows and braces and other types of appliances that were selected by EDSers for EDSers, and of course we have our EDS awareness shirt for our May EDS awareness activities. So we appreciate you checking the store out. And thank you again, Doctor. Any final comments? Okay, I think we are a wrap. So thank you all for your patience as we get started, and we're going to conclude this evening. So thanks again for joining us.
Thank you, everyone. We'll see you next month for Dr. Jekyll, the OBGYN, and also on May 19th for Dr. Tinkle. Take care. Good night.
Good night.